Hi, I'm Dr. Bojana Yankovic-Weatherly, and I'm excited to bring you these conversations with Dr. Mayoni Gunaratna. She is a women's health expert from the UK. In these next two episodes, we're going to be talking about perimenopause and menopause. In the first one, we're going to cover what perimenopause is, and we're going to talk more about the early stages of it, what are the common symptoms involved, as well as how to treat them. In the second episode, we're going to be talking more about the later stages of perimenopause, as well as menopause. What are the common symptoms involved in these stages and how to address them with evidence-based modalities. I know that both Dr. Mayoni and I can agree that there are many, many more topics and deep dives and studies that we wanted to share with you that we did not get to during this time. I hope that we will be able to do so during future episodes, including more information on supplemental supports, other pharmaceutical supports, as well as other integrative medicine modalities. I do hope you enjoy this conversation, and thank you for listening. Hi, everyone, and welcome to our conversation about women's health, hormones, perimenopause, and menopause. I'm Dr. Bojana Yankovic-Weatherly, and we have a very special guest today, women's health expert, Dr. Mayoni Gunaratna, who I met at a conference several months ago in Lisbon, Portugal. It was a longevity summit, and I really resonated with some of the things, Mayoni, that you had to share. So I'm very excited to have this interview with you today. Just to share with everybody a little bit more about you and your experience and expertise. Dr. Mayoni is a former NHS surgeon. She is the founder of Human Health and Skin Fit and medical director of the clinics by Dr. Mayoni. She felt that conventional healthcare structures kept people moving toward illness rather than being more health-facing. And the services her team delivers allow an upstream level of care to really help women overcome the health blocks and stand between them and their highest potential. She's used her own medical journey and experience of training and working in the NHS to help colleagues who want to support with alternative careers. And she herself is a mom of three, a wife to a talented artist, and together they roam on wild holiday in the UK and abroad. Mayoni, thank you so much for joining me today. And I'd love to start off with just asking you a little bit about how you entered this women's health space, and especially coming from a vastly different profession as a surgeon. I'm really curious to hear a little bit about your journey before we dive into hormones.
Sure. Firstly, thank you so much, Bojana, for having me. This is such an honour. And it was a really fortuitous conversation on the steps outside that beautiful venue that kind of has led to this. So, there are no accidents. So I'm really grateful to be here. Thank you. And yes, I think I've often sat and wondered why I've had such a kind of checkered past. But I think in answer to your question, how did I start this journey? Well, I'm a woman, first of all, and I think you've described part of my roles, some of my roles, but I'm also a daughter, I'm a sister, I'm all the things that women are. I'm a friend, it's being a woman is really the qualification, I think. And then I'm just incredibly grateful for my medical training. I entered the world of colorectal and pelvic floor surgery. And just prior to that, so in the middle of my training in the UK, you have an opportunity to do some research. So I then applied and did a PhD looking at the pelvic floor, but looking at fecal incontinence. So it's a really unglamorous part of surgery, and it was kind of literally in the bowels of the hospital, the research department. It was run by an incredible professor, Prof. Williams, who's actually gone on to become the president of the Royal College of Surgeons here. He's served his term now. And he was my mentor, and he was incredible. But we looked at women. Basically, my clinics were full of women because fecal incontinence affects at least twice as many women as men. And these women were, that we know of, I'm sure it's higher, that's the reported numbers. But these women were, number one, really tired and exhausted. They were in their 70s and 80s plus, usually. They had suffered for a very long time since childbirth, and then often accelerated symptoms after the menopause. And it really got me thinking, because we were only able to offer them surgery, and surgery was pretty brutal. It was either kind of reconstructing their sphincters, either giving them a neosphincter, or creating an electrical stimulation to the sphincter, or a stoma. And that was it. Like, these are women with non-cancerous conditions who are ending up with stomas, if we could operate on them at all. So not only had they suffered for almost half of their life, we were then not able to help them. So that really, as a young, I was in my early 20s at that point, and I remember just thinking, wow, is this like what happens to women? But I hadn't really appreciated it. Then as my career went on, I continued my colorectal training, and then I had my moment of just realising the NHS, I'm not here to NHS bash, because I think it's a wonderful system for sickness, for acute illness, but it's not set up really to help people with chronic conditions, and certainly not for women to manage the perimenopause. I left at that time, and I had my kind of absolute not a breakdown, but I really was soul searching. I did not know what I wanted to do. I ended up, I had therapy, I spoke to lots of colleagues, and I set up my own clinic at that point in aesthetics, which was really, I realise now looking back, an access point. It gave me the opportunity to talk to lots of women who then, took me into their confidence, which is an incredible honour. As you know, that's that beauty, the privilege of being a doctor, is being told things about, by people who may not have shared it with anyone else. And actually, it was happening in these rooms because I was spending, an hour with people maybe, or repeatedly seeing people. And as a result, Skin Fit, Mind Fit and Body Fit was born, which is really this kind of holistic approach. And then COVID happened, and really just fast forwarding to now, I've just streamlined everything. And for me, it is about helping women to optimize their health from an inside out approach, really. So anything I can do to help them to really optimize their cell health. I've completed my functional medicine training, and then I've also gone on to co-found the British College of Functional Medicine in the UK, which is really here to help doctors to offer functional medicine, because it's actually really only recently coming out of the kind of darkness here in the UK. So it is becoming a much more recognised sort of part of medicine, but it's still got a long way to go. So that's kind of me to date, if that helps.
Yes, thank you for sharing your story professionally and personally. And I think that I completely agree with you. We're seeing the same trend in the US. There's definitely more and more interest from physicians and from patients as well. So more people are seeking a more proactive approach, looking at what are some of the additional options that we can pursue, other modalities that are also supported by evidence, that may be supportive to their health, and that may be, as you said, looking upstream of disease and really kind of focus on prevention. But at the same time, I think that a lot of physicians share this frustration of dealing with one problem at a time in clinic, not being able to look at the whole picture of a patient, and also just having a limited scope of modalities sometimes to deal with. And I think that I really share with you that passion for being able to combine functional medicine, integrative medicine, these modalities that have historically been supported by evidence, by clinical experience, that unfortunately are underrepresented in a lot of clinical settings. So let's dive right into perimenopause and menopause. Today, we're going to talk about women's health as specifically at these stages of life. So why don't we do this? I'll go ahead and define perimenopause, and then we can dive right into talking a little bit about some of the symptomatology. How do we typically address them in clinic? What do the studies say? And then we'll do the same for menopause. So usually for perimenopause, menopause, unfortunately, it's something that we never studied. Certainly my generation did it in medical school or residency training. It was not just under-addressed, but just not addressed at all. But it's this pretty significant time in a woman's life that can be approximately 10 years leading up to menopause. So if the average age of menopause is 51, 52, perimenopause can start in the early 40s, but it can also begin even in her late 30s. And it is oftentimes marked by a multitude of physical, emotional, and cognitive symptoms that unfortunately for decades have been dismissed. And so a lot of women feel this sense of disempowerment. And certainly we hear a lot when people come to us that their hope is that they can, be in a more proactive role, learn more, they can be validated and listened to because they haven't been in the past. So a lot of the symptoms that occur during perimenopause are because of these fluctuations in hormones. And so typically in this early stage, we see that due to reduction of the quality of follicles in the ovaries, we see that there are some patterns of increased ovarian stimulation, meaning that our pituitary hormone FSH is increased and tries to kind of stimulate this ovarian follicle development. As a result, we can see an increase or rapid fluctuations in wild fluctuations in estrogen levels. But what we also see simultaneously is a drop in progesterone that in this early part of perimenopause can result in this estrogen dominant state. And with this estrogen dominance, there is a whole host of symptoms that can happen, usually, as I said, in our late 30s, early 40s, that women are like, what is going on with me? So maybe let's start by speaking a little bit more about that. When patients come to you in this stage of life, I'm curious to hear, and I imagine our clinical experiences and approaches are very similar. What are the symptoms that they come to you with, and share with us a little bit about how you start to address them?
Thank you. Yeah, absolutely. And that's a beautiful description of what happens. And I think it's absolutely critical that I think we as a medical profession and also women and the general public appreciate that the perimenopause is possibly the most powerful time we have for change. It's a real window into health and optimizing our health. So it is really not a time to sit back and just accept whatever's coming your way. And I would encourage, I'm trying not to be too militant, but I've kind of become quite vocal in this because I really think women are responsible for their own health. We can't sit back and expect everyone else to kind of do it for us. And the perimenopause is this incredible window. So that's absolutely, I applaud that. And I think the other really important thing is there's lots of things that happen. And I think what we were taught at medical school is, a very simple axis between the brain, the ovaries, and then the uterus, and that's it. Like that's the feedback loop. The reality is it's far more complicated. All the other organs, we are a multi-systemic creature. We also interact with our environment as well. And if you have a spiritual kind of thinking and philosophy, there's that element to our health as well. So we are certainly not uniaxial, as I kind of think of it. And I think, so being respectful of that is really important. But it's complicated. So I think to distill it into, I kind of think of it as a triangle, and it's a triad really, of low progesterone or dropping progesterone, of metabolic inflexibility, and a high cortisol state, especially for the women that I see. I'm sure you see similarly very driven, very kind of busy women in this post-COVID 2024 world where, we are part of this sandwich generation of women who are doing lots of things. So the kinds of symptoms that women if we kind of look at each of those areas, the dropping progesterone, remember progesterone's a neurosteroid primarily. It does, yes, it has reproductive functions, but when it starts to drop off, women start to experience that anxiety, that edginess, the sleep loss, so they're not able to fall asleep very easily. It's that classic sort of story of I'm exhausted in the day and then I get into bed and I'm wide awake. And that is very classically, I think, progesterone related. And it's this loss of resilience. They kind of start to feel really edgy. Everything's really up close and it feels very personal. So those are kind of some of the progesterone type symptoms that women talk to me about. Have you got any others? I'm trying to think if there's others specifically. But
yes, I'm so glad you brought both of those up. I think that along with that, kind of what you related with respect to that irritability can come a great deal of anxiety as well. And again, that could be that balance between estrogen and progesterone. And it's interesting because I hear from a subset of my patients that have gone through menopause, I have a subset of patients that say perimenopause was a lot worse than menopause because they really felt that because of those fluctuations, because of these imbalances and such a massive transition, and of course, not to mention different stage in life, typically, usually if a woman has children, she's likely caregiving for them during that time as well. Whereas later on in menopause, it's less likely so. And so there are a lot of things happening, but I do hear that from people that this was a lot harder than once I entered menopause. So a lot of the mood symptoms, memory symptoms as well, and sleep, absolutely. That feeling of, tired and wired, but not really able to sleep, waking up multiple times a night is such a classic sign of that low progesterone state and high cortisol.
Yeah. And I think another common sort of reporting is maybe not the symptoms, but this sense of fear, because women, and I remember this is when I first started to think, am I actually losing my mind? You start to go from being a very highly functioning, multi kind of sorting out person that's on top of everything to someone who's just suddenly crumbles, or you walk into a room and you cannot remember the name or the thing you were meant to be doing in that room, or a lot of my patients actually say they can't. One lady can't remember her boss's name in meetings, and it's just incredibly demeaning and embarrassing. So for me, those progesterone symptoms are very, very much the ones that women lead with. I would also say, to then tie into that, the reproductive, the kind of sexual organ function part of that is the irregular periods, and these are the kind of, so periods start to either get longer in length, or they tend to get shorter in length and heavier, or they become erratic. So the cycles, women are having short, long cycles, through their that year, for example, and a lot of my patients have had their children later, and so they may report their periods have never gone back to how it was before. So they're kind of in their late 30s when they've finished their sort of childbearing years. And then they're kind of getting to their early 40s and they often say, my periods have never been the same cycles as they were before my children. And that for me is a real sign that their endometrium is not being maintained, because that progesterone is just falling off a cliff, basically. So there's quite a few progesterone symptoms that I think people come with. In the metabolic inflexibility kind of part of that triangle, I often describe it as this weight loss resistance. I'm sure that's a kind of well-known phrase where women say, I'm doing all the things, I'm eating really well, I'm exercising really hard, but I just cannot shift the weight. And what is happening really is our power packs, our mitochondria, are losing that ability to use different energy substrates to fuel themselves. So your cells are not able, it's like having a battery that just is beginning to get tired by about 1 in the afternoon. So you're actually unable to sustain that energy level. Your body will often then produce a cortisol response to try and keep things going. You may be already in a high stress state, but that inability to switch from, using protein to using carbohydrate is very much this loss of estrogen, that declining or fluctuating estrogen pattern that manifests physically in this usually estrogen dominance, but then that often shows itself as this weight gain that is around the middle. It's really hard to shift. It's usually that last 5 or 6 pounds that women kind of really get annoyed about, that is significant there. And then as part of that also, there's this disruption in your testosterone balance. So women may describe a kind of acne-like hormonal acne, which is classically around the jawline, classically in the run-up to their periods. But to be honest, I don't know that it's specifically related to cycles, especially if cycles are erratic now anyway. And it's just this exasperation and embarrassment of having acne again like a teenager, but your periods are changing. So that's an important part of that triangle there. And then finally, cortisol was the final piece to that. And I think we touched on it. It's just this, the pressure on women now. I mean, the pressure's always been high on women. And I think we probably put the most pressure on ourselves. You may be under pressure at work because your job is either up for grabs, or you've got less people in the office space because actually cuts have been made. You want to keep career climbing, which is totally within your right to do so. And your children have probably got to that point when they're teenagers and they're beginning to, need you more presently for emotional support. So I just don't think the pressure has been any higher for women. And then you put in our hormonal changes and the fact that we can't remember our boss's name when you walk into a pitch. That's pretty poor, that's really, it's just off the scale, I think.
It's so true. And I love that you validated how often women will feel that, what is wrong with me? Am I going crazy? This real feeling of loss of control, this feeling of loss of resiliency, and how many different factors are really involved in that, from within, of course, the changes that we talked about, but also from the environment that we're in, whether it's in our home, whether it's in our work environment, our social environment, a lot of different pressures. And then on top of that, oftentimes, again, which I see with my patients as well, is that we put so much pressure on ourselves, to be the ideal mother and worker and partner and daughter and friend and all of these different things. And this is, again, part of the art. And I know we'll talk a little bit about mind-body modalities and so on, but really cultivating that compassion, truly working on that, because I think that's such another under-discussed skill set and a really important modality to practice and to work on, and that's actually quite necessary. We really do have to gain a deeper appreciation and just understanding of it's okay to feel this way, and by normalizing it, by accepting it, we're better able to cope with it, address it, be at peace with things that maybe cannot be addressed right now. But I think that you've really nicely outlined, many, many different components. So let's now talk about, in terms of some of the modalities that you typically discuss with patients, right? And oftentimes, in the ideal world, right, we like to kind of give people 20 different things to do and, hear all of the things that are going to help you feel better. But then in the reality of their world, right, the nutrition may not be perfect. Some of the other recommendations may not be, because again, we live in the real world. And I always share with with my patients, I'll send them follow-up summaries after my visits, and I'll always say, know that there's going to be detailed information here, but I don't expect you to do everything at once. I recognize that that's very overwhelming and not realistic. I just want you to be empowered with the information that's here, and let's select our priorities. And so with our nutritionist and health coach, they select, okay, here are our goals. These are the things we're going to work on. This is what's realistic for me now. So let's talk a little bit about that. In that kind of earlier stage of perimenopause, what are some of the interventions that you generally recommend, from lifestyle and nutrition to spiritual, possibly, if people are interested, to some of the supplemental and prescription medications?
Sure. Yeah, great question. I think what you've described and what you do is very much my approach, in that I've put that together in a program, and I'm sure you've got many programs too, but Thrive is my program where really we take women through these processes in a group as well as one-to-one. And so the first part of that process is really mindset work, because I think until a person is ready for change, there is very little I can do to help them. Really, honestly, I mean that with all the love. I want to, but what I've learned is to be patient. I have to sit on my hands and just wait. But which is totally the opposite of what I did as a surgeon, right? I'm like, right, I can operate, I can remove this stuff. So this is totally like, having to just wait. And then in the mindset piece, I really encourage people to set goals, but visualize, where do they, why have they come? How do they see their life? What is their 3 month, 6 month, 1 year goal? And then working backwards from that. And then ideally, maybe longer goals, but they can feel very unachievable. So for me, goal setting is a really core part of that. Putting those goals somewhere that you can see them every day, and like I say, trying not to make them too big, because it can be overwhelming in the beginning. It doesn't mean you can't have them, but I think they need to be broken down into really manageable pieces. So it could be, I want to run a marathon next year. How is that going to happen? Well, I'm going to have to go and buy some trainers first. Like, I've got to get some proper running shoes. I'm going to get some new kit too. I might just join a 5K group in the park, or I might just start walking more, So it's got to be manageable stuff. And then the next piece, for me, one of my really important pillars is nutrition. Absolutely. We've got to, I don't know about you, but my women do not eat enough, I'm afraid. And I think they're probably still the generation that grew up on those very restrictive diets from the 80s and 90s, the kind of low calorie, low carb, low everything. I don't know what we ate, quite frankly, lettuce leaves. And so encouraging women to eat is a really important piece of self-care, but also we need food, we need nutrition. So looking at what they're eating, how they're eating. Is it on the hoof? Is it like in the car before they drop off the kids? Is it kind of at their desk? So really kind of trying to dial that up. So we're dialing up their parasympathetics, because the more we're in a state of rest and digest, and our vagus nerve, I'm sure your listeners are all over this, but the more that is dialed up, the more we're going to get the goodness out of our meals, and also just bring that sense of calm to our life, which is really powerful. And using, even just eating, mindful eating can be really helpful for that. And I think also for me, the going back to the what are they eating, not only is it the kind of calorie content, but the protein content is really powerful. I try to encourage women to eat meat, which may not be everyone's kind of cup of tea, but I think the more sort of lean meat we can get into us, the better as a source of protein for women. It's just, it's just the right level of calorie content, fat content, and that protein turnover is what our gut needs as well to keep us in balance hormonally. So protein, I kind of try and help them visualize a plate of food. So half protein, and then the remaining half is split into a quarter of vegetables, ideally the colours of the rainbow type vegetables, minimally cooked ideally, and then the remaining quarter is complex carbohydrates. So ideally stuff that's either comes out of the ground or is grown in nature rather than complex carbs that we've made. And that usually helps them. Obviously, you know, that may not be the case for every meal, but just helping women to kind of guide them with that can be really helpful. And actually, I find that women do want to do it. They do want to cook for themselves. They do want to eat well, but they just don't have the time. So encouraging them to think about batch cooking on a Sunday or getting their kids involved. I've got my kids chopping vegetables for me and stuff, and that's, you know, getting them making your prep for the week is just really good fun. And it kind of takes some of the guilt out. I think we're really good at putting ourselves really way down on that list of self-care. So the more we can relieve that guilt, the better. So that the nutrition's a really important one. I'm sure there are other parts to that, but I'm trying to kind of top line it for people. And then joyful movement is a really key pillar for me. That's really bringing a sense of movement to your everyday, which is something you want to do. It's not punitive, it's not compensatory, so it's not making up for having had a bottle of wine and takeaway last night, because quite frankly, nothing can, I'm afraid, make up for that. Like, it's done, move on. Choose better next time, maybe. But exercise that kind of, like I say, I like lake swimming. There's like a lake that's been converted and cleaned up near us. I love that. You know, dog walking, anything. It doesn't matter. It does not have to be like a kind of classic image of someone running, or it could be anything that makes you move in a joyful way. Because again, the joy that you get from that is, number one, what reinforces your behavior, but it also stimulates your vagus nerve, right? Like, your vagus is really the core nerve that I think is important for us to sort of think about optimizing now. It just does so much, you know, and for busy women, we want things that do lots of things, right? And the vagus.
Exactly. Yes, exactly. Right. We want to do something that's very goal oriented, and I couldn't agree with you more. Again, you know, I think that it's definitely the first criterion for selecting activities, movement activities, is what are you actually going to do, and things that you're actually going to do are things that you enjoy. So if doing certain specific exercises that are prescribed to you, if that's just something that absolutely you're never going to do, okay, find something else, because ultimately consistency is important. And so this is what we seek to find with our patients as well, between myself and our nutritionist and health coach, our integrative health advisor. Let's identify activities that you absolutely love, that you are enjoying committing to, as opposed to me prescribing specifically what to do. And yes, we want to keep in mind that sarcopenia, or loss of muscle mass, is a reality. And so we want to incorporate some strength training. We want to incorporate some zone 2 exercise, because that's very beneficial for our cardiovascular system. But at the same time, it has to be things that they're going to do, because I could tell them a perfect prescription that has zone 2, zone 5, strength training, all of the different components. But if they're not going to do it, it's of no use. So let's identify those things. And in my personal practice, I combine dance, I do personal training, I do walks in this area that allows dogs to be off leash. So we kind of do these family walks with our dog, but it has to be things that you enjoy, and then ultimately things that are going to really support that vagus nerve getting into that parasympathetic state. And actually, to that point, you know, some patients ask me, should I be doing all of this high intensity interval training, and should I be doing, and a lot of that does increase our cortisol levels. And we see this when we check salivary cortisol levels over the course of the day. We can see a spike if there was exercise, which is normal compensatory mechanism. Our body is responding to stress. There is oxidative stress when we exercise. We certainly feel it, and our sympathetic nervous system is revved up. I still tell them, if this is something you enjoy, you love doing, do it, but make sure you combine it with other forms of exercise too. If it's something you absolutely hate, that's okay. Let's find other things you're going to do, as long as you're not sitting down all day, or sometimes even alternating, having a standing desk. And so I will do sometimes this as well. Stand on my standing desk, sit, try to move around in between. We kind of do what we can. And then to another thing that you mentioned, I really kind of wanted to piggyback on that. You talked about goals, and you talked about goals that are very specific. And one of the acronyms that we use are the SMART goals, right? Like our specific, measurable, achievable, relevant, time-bound goals that we can really be very targeted and intentional about. So instead of the goal being like, oh, I want to lose, 5 pounds in 2 months, it's like, no. Let's talk about specifically, I'm going to exercise X many times a week for X many minutes, doing this, and this. And it's really, as opposed to kind of then focusing on the scale, oh my gosh, did I make it? We're focusing, did I do my exercises today? Did I get in my veggies like you talked about? Did I get enough vegetables on the plate? Did I get enough of my antioxidants and enough of my healing nutrients in, as opposed to focusing on just one single number on a scale that's far from all the information that we really need to assess whether we're in some way on track, and whether we're honoring those goals, and whether we're living a healthier lifestyle.
Sure. And I think also, just to go back to your comment about cortisol and exercising, I think absolutely when we look at salivary profiles, you see this natural high awakening response of cortisol at about 6 a.m, right? So exercise, and then that drops off through the day. And by 4 or 5, by about this sort of time for me in the UK, this is the time my cortisol levels are definitely reaching their lowest end. So for me to now join a high impact class would be madness, right? But I often hear women say, I finished a long day at work and I go to my, Keep Fit class. I mean, they're not called Keep Fit now. They've all got really sexy names. But essentially, high adrenaline classes, right? That are just, it's like when you start to see and understand the physiology of your body is gearing you up for sleep. So the last thing it needs is a massive hit of cortisol, which is, we didn't really talk much more about cortisol, but cortisol obviously drives up adrenaline, which itself is going to give you all the symptoms of anxiety potentially, but it gets you ready to run away from the bear, but not if you're then trying to go to sleep too. You're going to be lying in bed just heart racing, feeling quite anxious, dry mouth. But equally, cortisol will drive up your glucose levels in your body. It will just drip sugar into your body. And then that will potentially, and if sustained, you will start to see a rise in your insulin levels too, which feeds into this whole metabolic picture that we start to see in the perimenopause, which is fascinating. I think this is why, for me, the perimenopausal window is so powerful, because we can start to regain some of that metabolic flexibility back too, by really looking at these chemicals and these hormones that we're accidentally releasing into our body because we're doing things we probably shouldn't be doing.
Yes, definitely. Yeah. So in addition to these nutritional guidelines and lifestyle and exercise guidelines, share with us a little bit about what is your typical approach. And I know this is a very lengthy topic that we could really get into details on, which we might do in the future. But if you kind of can share with us a little bit about your framework on, some of the medical or supplemental interventions, whether we're talking about oral micronized progesterone for women in perimenopause to address those declining progesterone levels, or specific supplemental supports that can address some of the nervous system issues or even some of the metabolic issues that we talked about.
Yeah, sure. So I think for many women, they will come to me in a state of often distress, and that is very much the progesterone kind of cluster of symptoms. And using hormones sparingly, I think, is really powerful, because you can really, for me, it's not about hormone suppression or replacement, really. It's about hormone balancing. And I think when you approach it like that, and if my patients understand it like that, it reminds them of the importance of all the other things. And in fact, I would probably say those other things are possibly more important than the hormones on their own. And certainly if a woman wants just hormones, I'm probably not the right practitioner for them, because I know the limitations of that journey. So we can use hormone replacement therapy to support women. I specifically prescribe bioidentical hormone replacement therapy, which is using the naturally occurring hormones that we find actually in the yam, for example. Disogenin is used. This is an extraction from the Mexican yam, and it can be, and it's created and compounded specifically for that woman. So I may suggest that she needs, say, 50 milligrams of progesterone at night. And so the specialist pharmacies, these are compounding pharmacies here in the UK, I believe similar in the US, that are regulated. They are all very highly kind of held to very strict standards, and they're inspected by our regulatory bodies here in the UK, the MHRA. And it's essentially like having a Savile Row suit made for you. That's how I describe it. It's like getting someone to create a beautifully bespoke suit for you, so that prescription is made specifically for that person. There are lots of other available options. Body identical is another phrase that women may hear. That is, again, using the same naturally occurring hormones, but made in a very set range of formulations. So 100 milligrams of progesterone right through to 200. Estradiol the same. So it's a fixed formulation, but that's fine, because for me it's actually understanding what the hormone is that's in it that's powerful. That hormone, women may also have come across synthetic hormones, and these are the progestins, for example. I personally don't prescribe them because of the evidence that supports the fact that these hormones, because they're clunkier, they're not quite a match for these receptors on our body. There are significant side effects and complications, and it's these that are the ones that are kind of always reported, and that's why HRT has had such a bad name, because actually the complications are related to the side effects of the synthetic hormones rather than the kind of more pure, very equivalent hormones that we can also have access to. So I use BHRT to support and to balance. And then to your point, I'll also, and sorry, just to add, within that progesterone, you've got estradiol. I'll also use testosterone, which I think is massively underrated here. Only a few days ago in the UK, there was an article in the papers poo-pooing testosterone, and I couldn't believe I read that. It was in one of the mainstream newspapers. And for every step forward we make in women's health, like something like that takes us 10 years back. And I had women contact me saying, oh my God, am I going to get hairy? I'm on testosterone. And testosterone is incredibly powerful. It has so many points of action. It is absolutely essential, really, for muscle health, bone health, brain health as well. Cardiovascular health, it's very strongly associated with as well. So, and actually, interestingly, we have a very small amount of it compared to men, but actually it is the highest, it's the most concentrated hormone that we have in our body. We have more testosterone than we have estrogen. So that's how important it is, ladies. So, any small drops in that, we really start to feel the effects of it. And women describe that not just sexual libido loss, I kind of call it your vavavoom, your general get up and go for life. It's that pile of laundry that's been sitting there for like 2 months and you just can't be bothered to go and fold it. And actually you start to do those jobs and those tasks when your testosterone levels start to balance out. So, yeah,
I'm glad you mentioned that. I was at this conference a few months ago, this internal medicine conference, and there was a talk on testosterone, and they were talking about testosterone replacement in men. And then there was one slide on women, and it was mentioned that the only country where testosterone is approved by their equivalent of the FDA for women is Australia. And so it was said at this conference, if you're not in Australia, don't prescribe it. But it's so interesting because when we prescribe hormone replacement therapy, what can happen naturally is if you're prescribing exogenous, meaning outside of your body, coming from outside of your body hormones, that's going to cause something called the sex hormone binding globulin to go up. And if those levels go up, they can also bind extra testosterone, which means there's less free testosterone available. So then, as you said, if there's this imbalance, if there are low levels of free testosterone that could be causing lower energy levels, low libido, that could be contributing to body composition, to loss of muscle mass, then that is something where testosterone may be considered. So I am curious about why aren't there more studies on this? Why isn't there kind of a more proactive methodology to really approving this, to understanding it better? Because it's still really not the mainstream. And you'll hear different things at different conferences, because I'll attend functional medicine conferences or longevity or anti-aging conferences, internal medicine, and there's different messaging by, different experts.
Yeah. And I think, the more I've read or tried to find out more about the effects of X in perimenopausal women, what has become abundantly clear to me is that there isn't any. And when I've looked into this further, and this was a shocking statistic, is that there is so women were excluded from research till 1991, right? So we were actively excluded from drug trials after the thalidomide, horror stories. From then onwards, and it was only, like I say, as recently as 91 that we were then allowed back in. And I find, it's this paternalistic kind of like, oh, they're there, these poor women don't know. And actually, so when I'm talking to women, I'm often basing my data and my reference ranges on white, 70 kilo, 45-year-old men, Caucasian men. Like, it's crazy, and when you start to look a bit deeper, that's all we've got, right? So, things are beginning to change, but it's going to take time. So I think, to your point, it's going to take time before that. And again, that's why I love personalized medicine. I always say to patients, you are your N=1 study, you are your own study, you're your own control. So get to know your body. And this is a lot of the early work we do with women, is getting them to realize that this symptom and this sign is connected to this underlying physiological process. When they start to realize that, and that kind of brain fog, for example, it could be from the sugar levels, it could be the cortisol story, it could be the estrogen imbalance, it could be even thyroid disease, like unrelated. So beginning to reconnect, because again, as women, we're very much encouraged by society, by ourselves, we're gaslighted, we disconnect, and we fail to recognize, and this is not to beat us up, because we don't need to get beaten up anymore, but like, we need to take up arms. It is a call to take up space and to go, hang on, no, that I don't feel good. There is something wrong. Okay, it may be called the perimenopause, but I'm not feeling good. It may be physiological, but I'm not feeling good. And it means that I can't be the best mum. It means I can't be the best career, person in this job role. I'm not the greatest wife at the moment because I'm so edgy. So, like, how is that a way to live for however many years till it's gone? Like, so no, I refuse to accept that this is okay. We've got too much life to live, really,
Exactly. So, yeah. And not just accepting that, knowing that we do have options, and knowing that we really have to advocate for ourselves. And if physicians are being dismissive or not really sharing the full scope of what the options are and not being willing to participate in shared decision making, because a lot of the guidelines, for hormone replacement therapy in the United States are based on shared decision making, evaluating risk versus benefit, and really involving the patient. We are way past the time when the doctor would say, okay, well, here's what you're going to do, and then the patient just passively does it. And this is really where our conversations are centered in my practice as well, is like we're collaborating together. I'm not just, yes, I'm providing information, I'm providing evidence, I'm providing studies and my clinical knowledge, but ultimately we're making this decision together. And then we're also monitoring, right? We're not just doing an arbitrary dose of hormones, and we're actually monitoring symptoms. We're monitoring, in some cases, we are monitoring labs as well. You mentioned, your patients calling you, is this testosterone going to give me unwanted hair growth or acne or whatnot? You measure levels, you track, how are your symptoms? Let's check your levels. You fine tune that dosing. And so we really aim to be as precise as possible, as personalized as possible. And this is where that precision medicine, personalized medicine is and should be going. And certainly obtaining more data from individuals that are representative of the populations that we're treating, and not just a subset of that population. And that was kind of one big thing. And maybe this is a good segue into, if we want to talk a little bit about menopause and Women's Health Initiative, and kind of how for a very long time, hormone replacement therapy was really something that I read a statistic. I think the numbers dropped to like 70% of by 70% of women who were using hormone replacement therapy before this big study, Women's Health Initiative, that we're going to talk about, came out. There was a 70% drop off of women that were on it over the years because of some of the dangers. And while there can be some risks of that we'll talk about that, a lot of the data were later debunked because the study population included women that were far past menopause, and now really our guidelines tell us that, okay, we certainly can consider hormone replacement therapy right at the onset of menopause, possibly for 5 years, maybe for 10, but it's generally not recommended past that age. And so when we look at these older women who were 65, 75 on hormones, it's not unexpected that they had higher rates of cardiovascular events, stroke, and so forth. But if we look at the actual target population that is coming to us, that's experiencing these changes, the risk-benefit ratio is very different for them. So now the medical community is rethinking this denial of HRT for the last 20 plus years. And a lot more doctors are more receptive to prescribing it, more receptive to having the discussion. But I think this is still something that a lot of women, when I give talks or when I see patients in my practice, there's still a lot of confusion about it.